Good morning, ladies and gentlemen. I thank the chairpersons for the kind introduction, and I thank at the outset the organizing committee of this 3D conference, more particularly Dr. Vijayakumar for giving me this opportunity, and more also for accommodating a little longer time for my talk, because I said the pathophysiology cannot be completed in 10 minutes time. So I thank him for the without wasting much time, I will go on to the pathophysiology of gestational diabetes. No talk on gestational diabetes can go without a proper introduction of the topic by none other than Matthew Duncan, who said that diabetes may come on during pregnancy. Diabetes may occur only during pregnancy, being absent at other times. Diabetes may cease with the termination of pregnancy, recurring sometime afterwards. And pregnancy is liable to be interrupted by death of the fetus, and the dead fetus is sometimes described as enormous. In fact, he has covered the whole gamut of diabetes complicating pregnancy. This is gestational onset of diabetes. This is true gestational diabetes. This is diabetes as a pre-diabetic phenomenon, and this is as diabetes manifestations or diabetic phenomena without diabetes being present during pregnancy. I will go on to the metabolism in normal and diabetic pregnancy. This is regarding, I have divided my talk into two parts. The part one will strictly confine itself to the pathophysiology and metabolism in normal non-pregnant state. In the normal non-pregnant state, by virtue of our intermittent eating pattern, you have a fed state and a fasted state. During the fed state, there is utilization of exogenous nutrients resulting in anabolism. And during the fasted state, you have production of fuels from the endogenous resources, therefore there is catabolism. Now let's look at it in greater detail. During fed state, carbohydrates are broken down to glucose, which is utilized for oxidation or stored as glycogen and lipids. Proteins are broken down to amino acids, and they are resynthesized as proteins and peptides in the muscle. And fat is converted into chylomicron, which is stored as triglycerides in the adipose tissue. Now, what happens in the fasted state is, after an overnight fast, the glucose is derived from either glycogenolysis or followed by gluconeogenesis. And if the fast is extended, that is the prolonged fast, you will find the third source is lipolysis, when you have free fatty acid, which serves as a major oxidative fuel. This is followed by ketogenesis, where ketones become an additional fuel. And this one thing we must remember is it can cross the blood-brain barrier. Now, in normal pregnancy, let us see what alteration takes place during normal pregnancy. In normal pregnancy, you will find in the fed state, after 100 gram oral glucose challenge, you will find levels of glucose, triglycerides and insulin are higher and more prolonged compared to the postpartum state, whereas the level of glucagon is suppressed. This facilitates anabolism. Therefore, during the fed state in normal pregnancy, you have facilitated anabolism. Now, in the fasted state, you have two things happening. One is persistent removal of glucose and amino acids, and two is the hormones of pregnancy being elaborated, which are called the super female elaboration of placental hormones. These two put together divert the mother to a fat metabolism to spare glucose and amino acids to the fetus, which ultimately results in what is called accelerated starvation. Now, what is accelerated starvation? Now, this is what happens in non-pregnant women. In non-pregnant women, after an overnight fast, you will find the levels of glucose, free fatty acid and beta-hydroxybutyrate are normal. They continue to be normal at 10 o'clock. They continue to be normal at 12 noon, even at 18 hours. On the other hand, if you look at the pregnant woman, after an overnight fast, her glucose levels are lower. Fasting glucose is lower, whereas free fatty acid and beta-hydroxybutyrate acid levels are normal. By 10 o'clock, glucose levels falls further, but free fatty acid levels and beta-hydroxybutyrate levels go up, and by 12 o'clock, that is about 18 hours after an overnight fast, there are changes of starvation which occur normally in a non-pregnant state after about 3 days. So that is why it is called accelerated starvation. That is the reason why we say that a pregnant woman should avoid skipping breakfast or even not avoid delaying meals. What are the factors that affect fuel metabolism in pregnancy? The placental removal of insulin, because placenta is an added sluice for insulin removal, and placenta is an endocrine organ, albeit temporary, elaborating contra-insulin hormones like estrogen, progesterone, HPL that blunt the insulin action. there is maternal fuel utilization by the conceptors. All of them put together are responsible for the changes that occur during pregnancy. One important point to remember is fetus is a continuously feeding border within an intermittently eating ghost. The message is that even whatever happens to the mother as far as the blood glucose level or other levels are concerned, the fetus will derive its glucose. It doesn't suffer from hypoglycemia that easily. That is about insulin. Now looking at the counter hormones, you see how they are progressively increasing, whether it is HPL, progesterone or estrogens, all of them progressively increases as pregnancy advances, and they reach the peak during the third trimester of pregnancy, resulting in greater insulin resistance. Now we will see each metabolism. Carbohydrate metabolism, the characteristics are insulin resistance, hyperinsulinemia, lower fasting plasma glucose and higher postprandial plasma glucose. Now let's look at the insulin secretory response in a pregnant woman compared to the non-pregnant state. As pregnancy advances, you can see the amount of insulin secretion. There is hyperinsulinemia, which again peaks during the third trimester of pregnancy. That is about insulin secretion, which is therefore reflective of the insulin resistance that takes place during pregnancy. As you can see in this slide, insulin resistance peaks during third trimester of pregnancy, which is responsible for the most frequent appearance of gestational diabetes mellitus during third trimester of pregnancy. That is the classical true GDM, which occurs as a manifestation only during third trimester. Now this insulin resistance of pregnancy caused therefore by hormonal changes of the pregnancy, increased concentration of free fatty acids in circulation and increasing maternal obesity. And the central role is played by the fetoplacental unit. Next is about the evidences implicating hormonal changes for the insulin resistance of pregnancy. First and foremost is the progressive increase in insulin resistance as maternal hormones increase progressively as pregnancy advances. Second is the production of similar insulin resistance when hormones of pregnancy are administered even to non-pregnant individuals. Thirdly, in vitro exposure of adipose tissue or skeletal muscle to hormones of pregnancy that blunts insulin-related mediated glucose uptake. What is more important is the clinical experience that each and every one of us have, that is fall in insulin requirement soon after delivery of even in established diabetes mellitus as well as GDM women. Any number of times you see patients who require even up to 100 units of insulin during gestational diabetes, who require absolutely nothing at all the moment the concept is out. So hyperinsulinemia of pregnancy is both quantitative and qualitative. Quantitative in the sense there is a 10 to 15% increase in beta cell mass due to hypertrophy and hyperplasia, and qualitative in the sense there is an increased beta cell responsiveness to secretagogue. Pregnant women are extremely sensitive to secretagogues and secrete much more insulin than a non-pregnant woman. Now we will go on to the blood glucose level. Fasting plasma glucose is progressively falls as pregnancy advances. In the second trimester, it is lowered by 72 hours of fast, but in third trimester, fasting plasma glucose is 10 to 20 mg/% lower after a 10-hour overnight fast. The causes for the lower fasting plasma glucose in third trimester are threefold. First, it is substrate deficiency because of its gluconeogenesis is impaired. There is enhanced beta cell function, which we already mentioned both in mass and sensitivity. And thirdly, the expanded volume of distribution of glucose. All of them put together lower the fasting plasma glucose level. Now at the same time, the postprandial plasma glucose level are much higher in pregnancy compared to normal pregnancy, normal non-pregnant state. So you find fasting hypoglycemia and postprandial hyperglycemia with wide glucose excursions, glycemic excursions during pregnancy. Now this is reflected by the criteria laid down by O'Sullivan and Mahan way back in 1964 following a 100-gram glucose tolerance test in pregnant and non-pregnant states. In the non-pregnant state, fasting cutoff point is 125, whereas 20 mg/% lower in the fasting state. On the other hand, the 2-hour value is 140 mg/% in the non-pregnant state, whereas it is 25 mg/% higher in the pregnant state. So we have fasting hypoglycemia and postprandial hyperglycemia during pregnancy. Now that's about carbohydrate metabolism. Coming to protein metabolism, in the fasting state, the HPL inhibits amino acid release from skeletal muscle, therefore you have hypoaminoacidemia. In the postprandial state, you have hyperinsulinemia being responsible for increased maternal uptake, and that increased amino acid utilization by the fetus also takes place, and there is a dilutional factor. All of them put together again produce hypoaminoacidemia in the postprandial state. So protein metabolism is aminoacidemia, hypoaminoacidemia, whether it is fasting state or postprandial state. Coming to lipid metabolism, one aspect is lipolysis and ketogenesis. There is increased HPL activity because of which lipolysis takes place, because of which more FFA is released. In fact, the levels of FFA is very similar to what happens in non-pregnant state after 80 hours. Here it happens in 14 to 18 hours, which I alluded to one of the earlier slides. That is the reason why accelerated starvation takes place. Triglycerides, exogenous source, food intake is increased, chylomicrons are produced, triglyceride level is 1.5 to 2-fold increase. Endogenous, because there is high levels of FFA, in the presence of high levels of insulin, more VLDL is secreted from the liver. Once again, the triglyceride levels go up. And lastly, there is a reduced clearance because of the reduced LPL activity in adipose tissue. So, combined effect is to have hypertriglyceridemia. Now, this slide tells you that there is a raised FFA level in the pregnant state, also raised triglyceride level in the pregnant state compared to non-pregnant state continuously throughout the day. If you integrate the whole metabolism of normal pregnancy, you will find whether it is anabolism characterized by insulin resistance, hyperinsulinemia or hyperglycemia, or catabolism characterized by lipolysis, ketogenesis or hypoglycemia. As gestation progresses, you will find the peaks and troughs in these changes widen, and you reach the peak during the 3rd trimester of pregnancy. Now move on to diabetic pregnancy. What happens to metabolism in diabetes pregnancy? Now, it is a question of balance between the beta cell function on the one hand and insulin resistance and accelerated fat catabolism of pregnancy on the other. You know that beta cell function is different in EDM and GDM. It is different between type 1 and type 2 diabetes. It is also different between 1st trimester and 3rd trimester GDM. Now, let us see what effect does it produce. In type 1 pregnant woman who is characterized by insulinopenia outside pregnancy, but she is extremely insulin sensitive. At the same time, she has inherent ketosis proneness. The moment pregnancy occurs, insulin resistance of pregnancy and accelerated fat catabolism are superadded. The superadded insulin resistance results in 1.5 to 3-fold increase in insulin requirement in these women, and this accelerated fat catabolism results in a tendency to develop diabetic ketoacidosis more rapidly and even at a much lower levels of plasma glucose level. And she does develop it on intravenous administration of beta agonists like ritodrin to arrest say premature labor. She may have diabetic ketoacidosis. DKA can be precipitated. In type 2 diabetic pregnant woman who is already characterized by chronic insulin resistance even in the non-pregnant state, who may or may not have a defective beta cell secretion. In addition, with pregnancy, the insulin resistance of pregnancy results in greater insulin requirement even more than in type 1 diabetic pregnancy. And the accelerated fat catabolism of pregnancy promotes ketosis in the face of calorie restriction and therefore impaired motor and intellectual development in the fetus. The implication is that there is a limitation for hypocaloric diet in obese type 2 diabetic pregnant women, otherwise she may land in ketosis. About 1st trimester GDM women who has insulin resistance of pregnancy plus additional insulin resistance probably similar to the chronic insulin resistance seen in individual at risk for type 2 diabetes. She is already a candidate for type 2 diabetes, shows chronic insulin resistance over which the insulin resistance of pregnancy is superadded. Therefore, her insulin requirement will be more than the 3rd trimester GDM woman, and she has a relatively higher rate of development of diabetes after pregnancy. Now, we will move on to the 3rd trimester GDM woman who is the true GDM, who has normal beta cell function in basal non-pregnant state, has only the insulin resistance of pregnancy. With the failure of beta cell compensation, she develops true GDM during 3rd trimester pregnancy alone. She is characterized only by insulin resistance of pregnancy. To summarize the event that take place, there is a super female elaboration of hormones of pregnancy. This results in insulin resistance and accelerated fat catabolism. This tries to promote compensatory hyperinsulinemia. The changes in the metabolism are accelerated starvation fasting and facilitated anabolism in fed state. So, as far as carbohydrate metabolism is concerned, you have fasting hypoglycemia and postprandial hyperglycemia, fasting and postprandial hypoaminoacidemia, fasting and postprandial hypertriglyceridemia, and elevated free fatty acid levels. Now, therapeutic implications of this, you have increased insulin requirement. 1st trimester GDM requires more than 3rd trimester GDM. EDM requires more compared to your pre-pregnancy state. Type 2 diabetic requires more than type 1 diabetic. And there is an increased predilection to diabetic ketoacidosis in type 1 diabetes and propensity to ketose in obese type 2 diabetic if hypocaloric diet is even. What are the implications of this as far as the fetus is concerned? The effect of glucose intolerance during pregnancy is a time-honored slide which everybody knows. There is a fuel-mediated heterogeneity depending upon the occurrence of glucose intolerance during first, second or third trimester. First trimester itself in type 1 diabetes and third trimester alone in GDM, you will find the changes in organogenesis, behavioral abnormalities or anthropometric metabolic changes. Next is about the pathogenesis, the so-called Pedersen's hypothesis, where with maternal insulin coming down, you have hyperglycemia. This hyperglycemia crosses the fetal beta cell, crosses the placenta, stresses the fetal beta cell to produce hyperinsulinemia, which is responsible for macrosomia. This has subsequently been modified to say modified Pedersen's hypothesis, where you have not only the glucose but also amino acids and lipids responsible for the so-called mixed nutrient effect, hyperinsulinemia. The growth increases in the fetus in insulin sensitive tissues such as the viscera, where it doesn't affect insulin insensitive tissues such as the brain. And lastly, there is a transplacental transfer of fuels and hormones. Glucose crosses, amino acid crosses, ketones crosses, but insulin and glucagon from the maternal side does not cross the placenta. To summarize again, hyperglycemia, however trivial, is teratogenic. Pregnancy is a tissue culture experience wherein nurture represented by maternal fuels modifies nature represented by the genetic endowment of the fetus. And a short-term effect, as Professor Anjalakshi made a statement in her beginning, a short-term effect, namely good metabolic control, has a long-range payoff in the form of a healthy newborn. Thank you very much for a very patient hearing. Thank you.